Okay, good morning. Thank you everybody for coming in. My name is Alex Jeffries. I actually work for ViaQuest Home Health, but I am happy to be here with you guys today on behalf of the NAIA conference. And for today's session, we have two clinicians joining us from Methodist Hospital in Henderson, Kentucky, just across the river. First, we have Dr. Judy Canlis. She's a psychiatrist and medical director of therapy services at Methodist Hospital in Henderson, Kentucky. She is certified by the American Board of Physical Medicine and Rehabilitation. Her clinical interests include neuromusculoskeletal rehabilitation, women's health, female athletes, sports medicine, non-operative spine, and electrodiagnostic medication. And we will also have with us Beth Taylor, also from Methodist Hospital in Kentucky. She is a physical therapist, oversees the Balance and Falls Prevention Program along with Vestibular Rehabilitation Program at Methodist Hospital. Dr. Taylor and Dr. Canlis, thank you for joining us today.
Good morning. Morning. It's a pleasure to be here.
I'll try to figure it out.
So today we're going to tackle a very broad topic. Actually, when I was preparing for this talk, I was thinking of all the different directions that this talk could go in, and hopefully we boiled it down to some of the essentials that you can take home with you and use in your everyday jobs. So just to clarify, I'm a physical medicine and rehab specialist. I'm also called a physiatrist. And the way that I like to explain to patients what that specialty is it's sort of like external medicine. I kind of help with a patient's overall function. So if you've lost function from an illness, from a chronic disease, an injury, then I work with a team, and I work with Beth often, to get you back to your prior level of function or the highest level of function that you can with that condition. So let's get started. For the first half hour, I'm going to be speaking, and then for the second half hour, roughly, Beth will be speaking, and then if we have time for questions, we'll welcome those as well. So, again, the objectives, we're going to establish the importance of addressing falls. This is geared more towards the older individuals. Discuss risk factors and risk assessment. We were talking in preparation for this. We wanted to also make the distinction between community-dwelling older individuals and what literature kind of cites as the frail elderly. Again, we're going to try to touch on some current data, and then if we have time, review some case studies. So I'm going to go through the next few slides quickly because I do want to get to the center of this talk, which is about the assessment. So the incidence is quite significant, up to 40% of community-dwelling older individuals, and that figure is even higher for those who are 80 years and older, will fall each year. And for those in long-term care facilities, about 50% of those patients will fall. And if you've had a history of fall, your likelihood of having a subsequent falls is just as much or higher. The direct cost and the direct burden on the medical system is quite staggering, in the billions, 34 billion as cited by the CDC. And those are direct costs. That doesn't take into account the indirect costs, time, money from families, other caregivers. So these are the direct costs. And for some reason that figure is going up. The literature isn't quite clear why this is going up. I have a suspicion that this is probably because our population is aging and living longer with a lot more chronic illness. And the effects of falls can be quite devastating. Most commonly cited are fractures and traumatic brain injuries. Of the fractures, spine, hip, forearm, leg, pelvis, those are some of the more common, but the hip fractures in particular can be particularly devastating to a person's independence. A large portion of those patients who sustain a hip fracture will not reach their prior level of independence following that hip fracture. Traumatic brain injuries, we see that a lot. Falls are the most common cause in older individuals, And of the fatal falls, about half of those are due to TBI or traumatic brain injury. And then lastly, and we deal with this a lot in our profession, is once a patient has fallen, they can develop anxiety about falling again. This leads to a more sedentary lifestyle, withdrawal from their community, withdrawal from, an exercise program. Patients can become more sedentary and as a consequence can become more deconditioned. And the mortality is also rising. And in 2013 they said over 25,000 individuals, older individuals, died from unintentional fall injuries. So there are several risk factors. You're probably well aware of most of them. The ones that are highlighted in red are the ones that are associated more with traumatic injuries following a fall. So those who have had falls due to syncope, a prior fall with injury, and then also if they are cognitively impaired, and this is particularly with the frontal lobes and their executive function, their ability to make judgments and problem solve. Those patients tend to have more injuries following a fall. This is exciting information, I think. This was recently published this year from the American Journal of Public Health. Sedentary behavior is identified as its own separate risk factor, independent of lack of moderate level activity. So there's activity, exercise, moderate level exercise that we know can be preventative, can be therapeutic, but it is distinct from the sedentary lifestyle. And Americans in particular were cited as sitting more than 6 to 8 hours a day on average, a large population. Dorothy Dunlop, who was one of the researchers in this article, said that for every additional hour adults over 60 spent sitting increases by 50% their risk of becoming disabled with ADLs or their activities of daily living and walking. This is a handout that I've started leaving in my waiting room and in my clinic. Patients can just pick it up and while they're waiting for me, read it. And I've noticed that a lot of people it's actually resonating with them because this picture doesn't even need explanation. You can see from a mechanical standpoint how detrimental this can be to the musculoskeletal system, let alone, end organs, heart, lungs, blah, blah, blah. So I like this information. I like you to kind of take this home with you today and just kind of think on that. So falling is a multifactorial problem, which demands a multidisciplinary approach or intervention. In my training as a physiatrist, a functional history is key. So when I see a patient that falls, or they're referred to me for gait dysfunction, I often will start by asking them, when was the last time you were independent without any assistance or any assistive devices? And a follow-up question to that is, when was the last time you were able to do what you wanted to do, not just what you need to do in order to get through your day? And so, you'll be surprised that, falling can stem back to, years. Oh, I fell about 5 years ago, and since then it hasn't really been the same, But then there are those patients that, I started falling this year because I was in the hospital and I think I just got weaker. And then I never really bounced back. So that interval of time, is very important when you're trying to establish the next two things, which is a rehab potential for a particular patient and also a goal-directed intervention. So prognosis, or what I like to better term as rehab potential, if a patient has a prior functional level of being sedentary, being wheelchair dependent, and then they happen to fall, they may have dropped their function from here to maybe here. So that gap is very small. Their rehab might help, but it's the patient that has a drastic change in their function in a short amount of time that we definitely want to intervene aggressively, and really tailor that treatment plan. I specialize in pulling a team of healthcare providers to help get that patient back to their maximal level of function. So most often it involves physical therapy, sometimes occupational therapy, and sometimes speech pathology if there's also cognitive impairment involved. I also try to evaluate if a patient needs assisted devices, and that can range from canes to a power wheelchair, depending on their diagnosis. Education is paramount, both for the patient and also the family, and then eventual transition to a home exercise program. We do not want patients to become dependent on therapy. We want them to be independent with a home exercise program at their maximal level upon discharge. So some considerations during my physiatric evaluation, because there's many different routes that a patient with gait dysfunction or balance problems can go. They can go to an ENT specialist, they can go to a neurologist, but if they come to me, this is essentially what I am thinking about for every patient. Every patient is different, but I try to touch on these things consistently. The musculoskeletal system and the neurologic system, trying to evaluate one or two or three components that could be affecting their balance. The vestibular system, I have to admit, until I met Beth, I wasn't really comfortable with, or even trained on how to evaluate the vestibular system beyond, they're having vertigo, turn your head a certain way and see if we can get it better. If not, send on to ENT. That really was the gist of what we did in training. But as I've gotten to know Beth and her training in vestibular rehab, I've really tried to include, at least a very rudimentary questionnaire and screening on, do you feel dizzy? Is that really dizziness, or is the room spinning around you? Is it associated with change in position? The vestibular system is a very complex system in the body, but it is one of the things that is probably under-recognized and something that we can do address from a therapeutic standpoint. Medication review and vitamin D, we'll go into that in the next few slides, but it's very important. And then also taking into consideration their other comorbidities. So let's touch on the musculoskeletal system. There are some things that we know are associated with aging. Loss of bone density, loss of muscle mass, degenerative joint disease, which is partly hereditary, partly lifestyle, and thinning tendons and thinning ligaments, as well as other soft tissue. So with a fall, if these things are playing a role, it leads to injury. Gait is something that we also evaluate significantly, obviously, if a patient's having falls. Changes that are associated with aging is a reduced speed, reduced stride length, reduced ankle control, general weakness in the lower extremities, and also postural imbalance, especially with the pelvic girdle. And pathologic gait can be roughly divided into 4 categories: deformity, weakness, pain, and impaired control from possibly like a neurologic condition or whatever. So these are important in evaluating because there's treatment that can be geared towards some of these, and some things that you can treat, some things you'll have to accommodate for. I also try to pay attention to the nervous system. A lot of patients who get older, they will have some element of peripheral neuropathy. Peripheral neuropathy, so the nervous system is divided roughly into 2, the central, which is the brain and the spinal cord, and then the periphery, which is the extremities. And on the diagram on the right kind of demonstrates a stocking glove distribution, which is the pattern of numbness and tingling, and sometimes pain that people can have from a condition like peripheral neuropathy. This affects a person's balance because if they cannot feel the ground underneath them, or they cannot detect changes in inclination or decline or uneven surfaces, that can affect a patient's balance. Some of those things those are usually things we will have to compensate for and make the patient aware when to be extra careful, when to use an assistive device. And then the central nervous system, a lot of patients walk in. I don't often make a diagnosis in my outpatient clinic of stroke, or Parkinson's disease. You can kind of suspect that they might have a movement disorders, and then I'll refer them on to neurology. But if they come in with a diagnosis of an insult to the central nervous system, that's important to outline, define, and also address through therapy and take into consideration when you have goals. So here we're going into sort of my one slide on vestibular because it is such a complex kind of system. It's roughly divided into central and peripheral, and the inner ear is the peripheral external part. And it gives information on, you know, the body and the head's position in space relative to the ground and the environment, based on how much you're moving your head and how much you're moving your body and how many different vectors you're challenging your body. That information then gets conveyed to the brain through, you know, in different areas. And so if a patient has vertigo, a lot of times we'll try to see if there's an underlying vestibular problem with that. But like I said, I'll let Beth go into that in more detail. So what is the evidence? You know, I think a lot of you are case managers and social workers, and you're trying to, you know, distill from the literature that's out there, what is the most cost-effective way that we can implement change and make a positive change on patients that are falling, because obviously that figure is going up. The two that are cited in literature that I came across the most was vitamin D supplementation and medication review. Those are cost-effective ways to reduce falls, especially in patients that are in the care facilities. The medications that are most commonly associated with affecting a patient's balance would be the ones that affect the brain and the ones that affect the blood pressure. Vitamin D. Now, how does vitamin D affect balance? You know, they think that it has something to do, well, we know that it has something to do with muscle strength and coordination. Vitamin D is a vitamin that kind of acts like a hormone in the body. It's also important for calcium absorption. Without vitamin D, calcium can't be absorbed, and without calcium, your muscles really don't contract, or you can't control them very well. So that's sort of the correlation between vitamin D in sufficient levels and also balance and gait. Now, vitamin D is also important for other reasons, so a lot of physicians are checking them these days. It's important for bone health, like I said, for calcium absorption. It's an important antioxidant. It's said to boost the immune system. So a lot of people are checking a vitamin D, and vitamin D deficiency and insufficiency are levels that are, you know, less than 30 or less than 20. And some, you know, the lowest that I've seen was, I think, like under 5, you know. It's called the sunshine vitamin because your body can make vitamin D or convert sunshine into vitamin D within the body. But if we do live in an area where, you know, especially last winter was particularly long and, you know, very, very icy and cold, and some individuals who don't feel comfortable getting out in that inclement weather will stay indoors. And so you won't even get any, you know, your body won't be able to convert vitamin D on its own. A lot of patients who are in care facilities don't go outside either. So that's probably, you know, that is the link between the vitamin D and care facilities. And then people in this area, I don't know, compared to other areas, you know, vitamin D is available through the diet, fortified cereals, dairy products, also fatty fishes. You know, you can get vitamin D in the diet, but if you don't get enough vitamin D, then you really ought to take a supplement. And the recommended supplement is 800 to 1,000, up to 2,000 units a day. I always check a level. You know, before I tell, you know, I'll tell them in addition to taking a vitamin D to go ahead and have their level checked, because the 800 to 1,000 is a maintenance dose. Now, you want to reach therapeutic levels of vitamin D in your body for, you know, for you to have any benefit. So you want to replace their vitamin D deficiency or insufficiency if it's low, and then maintain with these guidelines. And I actually had my own vitamin D checked, and I was insufficient. I was like a level of 27, and you know, you want it 30 or above. And so I started taking vitamin D, and on that first day, I felt like I could just clean my whole house. It was such a boost of energy. I don't know. It's supposed to have something to do with with mood as well. So. Okay, so now we're moving on to exercise interventions, and roughly they're divided into 4, sometimes 6 categories. Endurance, or the cardiovascular, the strength. Those are 2 things that people think of the most when they think of exercise. But then the other 2 areas, balance, flexibility, and then, you know, movement, what else did they say? And then general physical level of activity, people tend not to pay as much attention to. So at this stage, let's clarify between physical activity and exercise. Exercise is regular, scheduled, goal-directed activity that leads to the endpoint of fitness. And fitness can be, I need to do what I need to do at my job, or I need to play this sport, or I just need to, do my daily activities. Whereas activity, being physically active, is just being busy, or the end point is maybe to finish this job at work or finish this project at home, but it's not necessarily, I'm going to be fit. So that's the distinct difference. The literature, this is based on a Cochrane review. For patients who are in care facilities, exercise, I think it was a little less clear and inconclusive. In subacute settings, it appears effective. In care facilities, its effectiveness was uncertain. In the hospital, a multifactorial intervention, which includes exercise, was found to reduce falls. And then in care facilities, a multifactorial intervention had possible benefits. So these are things that are, this language is soft. We want, does it work or not, when we're talking to our patients. But, I don't think the literature is quite there, but there are more studies being done, so I'll be looking for those. The thing that was easy to measure and was found effective, again, was vitamin D. Now, for those living in the community, and we've talked about this, exercise intervention is good maintenance. If you're healthy and you want to stay healthy, then one of the recommendations, hands down, is to exercise. But if you're falling, or you've been falling, you really ought to be evaluated, I think. Exercise does have a purpose in reducing a patient's fear and anxiety about falling, but those effects might be more short-term than long-term, according to the literature. And the evidence is still insufficient. So these are terms and phrases that, when I'm looking at the literature, I don't like to see those in inconclusive kind of data. But that's where we are right now. Oh, I hemmed and hawed about putting this slide in there because I love yoga. I am very interested in Tai Chi. Tai Chi, again, yoga Tai Chi for patients who are community dwellers, otherwise healthy, not falling, keep doing it. For those people who have problems or are in a care facility, the data is, again, inconclusive. It's costly to implement these kinds of programs in a facility. People in facilities are at varying levels of independence, have varying diagnoses, have varying rehab potential. So to implement a program and say that it's going to reduce falls, I don't think that the literature or the studies are there yet. And in fact, this is from our own journal, the Archives of PM&R. Tai Chi did not have an impact on impairment, functional limitations, disabilities in the pre-clinically disabled older people when they did it for 24 weeks. That was cited again in the Cochrane study that I was just pointing to. And again, this is from the Journal of Alternative and Complementary Medicine. Yoga may have a beneficial effect on balance. But again, the design studies are poor. The reporting of data is variable. These are things that are hard to control. Even our literature in the PM&R world, it's hard to sham exercise and therapy. You can't tell a person, okay, we're going to give you this therapy, and then we're going to make up this therapy and give it to you, and then we're going to study it. It's hard to kind of sham therapy. So I think that's where the literature kind of gets shaky. So what is the take-home point about exercise? Exercise is good if you're healthy and you want to maintain. By all means, there's no argument there. I think it has to be a balance of increasing physical or exercise and staying active, and decreasing sedentary behavior, as I showed you earlier. So it has to be kind of a balance. And the exercise that they say you should get is a moderate level of activity. You don't have to be a vigorous triathlete. In fact, you have higher risk of injury if you go for very vigorous levels of activity. When I read that literature, I was like, yeah, because I don't like to run that much. But moderate level is easy to do. You just you walk. You can maintain a conversation. You're a little winded, but you're not huffing and puffing while you're running. That's not what I like to do when I do exercise. But there was an article, and I probably could have included it. Moderate level of activity shows the most health benefits, and then paired with the article that just came out this year, decreasing sedentary activity. So So take-home points again, if I haven't made them clear by now. Vitamin D and medication review, very helpful, especially for patients in care facilities. Interventions that are individually tailored to target risk factors, so individualized treatment, better than just a blanket standard package treatment. And then also reductions in sedentary behavior. That's it. So I'm going to turn it over to my colleague, Beth. Oh, is Beth's here for lecture?
It's on your jump drive, right?
Yeah.
This is yours. Oh, this is mine again. Your jump drive.
Yeah, I do.
Okay, I have to put it on. Well, we're looking for a jump drive, so let me see who I'm talking to today. Are there any physical therapists? One. Occupational therapists? Yay. Okay, so nurses? Social workers? What else?
Rehab there.
Rehab. Okay. Well, I work very closely with Dr. Canlis. We're 40 feet away from each other at probably any given point in the day, and do a lot of consulting between one another on our cases, which is a very good situation, as you can well imagine. We do see a lot of patients who have fall risk for lots of different reasons. Technical difficulty. Can y'all hear me? Do I have this up?
Is it on? She had a separate power.
How about now?
It's on my jump drive, but it's not loading the jump drive. Oh, this is the jump drive here?
Yeah, that's the jump drive right there.
Okay. Can we...
Is that it right there?
Is this it? Oh, this might be it.
I may have to wing it.
No, it's on here.
And this
I think we have to eject that and then put this. Let me eject it first.
Do y'all want to stand up a minute? Easy thing. Everybody stand up. Stretch.
How do you...
Feels good for a minute, right?
You should just.
Okay, why don't we try this? Everybody's on 2 feet, eyes are open, right? Okay, no problem. Right now you have, all your systems are on. You've got your vision, you've got your inner ear working, you've got your musculoskeletal system. Now nobody gets to fall down, okay?
Oh, this is it.
All right. So what if I put you on 1 foot? All of a sudden it's like, well, it's not really all that easy, right? Okay. All right, try this. Both feet on the ground. Can you stand steady with your eyes open? Now close your eyes.
Still loaded.
Do you feel a little bit of a sway happen? See how it happens when you take your vision away? All of a sudden, you've lost a pretty big piece of the puzzle on how we keep our balance. You can open your eyes now. So I'll just jump ahead while they're getting this ready, but we keep our balance 3 ways, basically, big picture. Your vision, your musculoskeletal system, and your vestibular system, or your inner ear. And so when we have our balance, you guys can sit down if you want. When we have our balance working and we're not dizzy, it's great. You don't ever think about your inner ear, right? Does anybody go around and think about your inner ear? No. But I'll tell you, if something goes wrong with that, you're miserable and afraid.
On.
Probably headed to 911 because it's so frightening. Has anybody ever had positional vertigo? It's bad, right? It's frightening. Did you think you were going to have like a stroke or You went to ER, right? Yeah, it's incredibly scary. But back to the balance for a second. If anything goes wrong with your vision, I mean, how many of our older people have a decline in their vision? Lots. And that is actually like the primary way that we keep our balance, is because we can see where we are. We know where we are in space. And so when we lose that or that's impaired, that's a big problem. The second way, like I said before, is the musculoskeletal system. So if you have pain in your extremities, or you have had a fracture, or you have weakness in your body, you can imagine how that also impairs your balance. And then the vestibular system, which is a whole other piece of that puzzle, but actually it's kind of like our backup system. We don't really know that's turned on all the time until something goes wrong with it. Really, your balance is like, it's a miracle. It's a miracle that we stand and that we walk and that we aren't always on the ground or hanging on to things. It really is. And if you've ever had something wrong with your vestibular system, you can probably attest to that. It just like rocks your world, like literally. So I don't know how to work this. Oh, okay. All right. So I thought I'd just talk a little bit about like how I look at people when Dr. Canlis or another doctor refers them to me. I want to know a lot about what is going on with this person. I want to know if they have fallen in the past year. How many falls have you fallen in the past year? How many times do you think you have fallen? And I've had people tell me that they couldn't even count. They've fallen down so many times they don't even know how many times they've fallen. So you know you have a big job ahead when you hear that. But I also want to know what caused you to fall. And surprisingly, a lot of people will tell me, I don't know. I just fall. I don't know. So then it becomes our job to kind of try our best to figure out, why are you falling? What is that? And what can we do about it? We want to find out if this person is using an assistive device or not. A lot of times they'll come to therapy without a device, but they have 3 devices at home. But they don't use it when they leave the house because they have pride. They don't want to do that. Have you ever seen that with your older population? Yeah, it's like, oh, I'm not going to give in to that. I'd rather, be on the ground somewhere than use a cane. Really, they kind of get to that point sometimes. So it's our job to kind of help them to understand that the assistive device is maybe not even something that you have to think of as a permanent thing, but until we can get you stable, we got to stop the falls, because you end up with a traumatic head injury, or you end up with a broken bone, and then life is just not the same anymore. I try to ask questions about their home or their work. What is it that you really have to encounter every day? Do you have, 2 flights of stairs? Is your laundry in the basement? A lot of times the laundry's in the basement, and you've got people that can barely walk climbing up and down the stairs. So you want to know those things. Try to get that subjective history as best you can when you talk to people, really no matter how you're interacting with folks on your job. You want to kind of figure out what is it that they're dealing with and what kind of help do they need. Because any one of you in here, if you see a problem or you're afraid that someone's going to fall, can alert someone to say, hey, does this person need to be evaluated? Do they need to go see their doctor and tell them about the falls? Do they need to ask for a consultation with a physiatrist or a physical therapist or an occupational therapist? And I think a lot of times, the general population just think, well, I'm getting older, I fall. But that's not normal to be falling down. It's just not what is good to do. So we need to get that stopped, if at all possible. We always do an assessment of range of motion, strength, sensation, postural dysfunction, and also their gait. One thing that you can kind of check easily for yourself, one of the big things about range of motion and fall risk is ankle stiffness. If you just take your foot and just work your ankle up and down and in and out, and round in circles. Do you feel like that's tight? Do you feel like that's stiff? Is it painful? Is it different on one foot than the other foot? Do you have hamstring and gastroc tightness that you're dealing with? Because those impairments at the ankle are very, very important, because normally we use what we call an ankle strategy to maintain to react. If you have stiff ankles and you can't react to a pebble that got under your foot because your ankle is so stiff, then there's this chain of events that's going to happen, and you can't react properly. So we try to train for ankle strategies and try to increase ankle range of motion and strength. That's kind of a big thing that I try to look at. And then, of course, strength. A lot of people, have you ever seen people walk where they have this? Have you seen that type of waddling gait? That's typically from gluteus medius weakness. It's the muscle that holds you up. So if you're standing and you stand on one leg and you see this happen, there's weakness in that hip. This muscle can't hold you up and hold that pelvis tall and steady, so you can see hip weakness just walking down the street. Sensation is another huge obstacle, because if you can't feel what's under your feet, that's in that whole big category of musculoskeletal. You can't feel what's under your feet, and so how are you going to react to it if you don't know it's there? When you have a decreased sensation in the feet, you really are going to have to rely on vision. And a lot of times I have patients that are looking at the ground all the time, and if I know that they can't feel their feet, I don't try to take that away from them. A lot of times you say, oh, don't look at the ground all the time. Well, they might have to, to keep from falling. And so sometimes you have to just, you have to accept there's certain compensations that have to be made so that a person doesn't, actually have that traumatic fall. Dr. Canlis and I are kind of junkies of postural correction. We do a lot of shoulder retraction, and when you see people with a high forward shoulder and that forward head, this is all tight, and you see that forward flex. They've lost their muscle balance and their postural stability, and so we try to, best we can, teach and train to bring the shoulders back. If you just squeeze your shoulders, think about your shoulder blades. Think about if you squeezed them down and back like you're going to put those shoulder blades in your back pockets, and how that pulls across the front of the chest and works the back side of the shoulder blades. So we work toward those muscles to try to get that postural balance. And then a lot of that postural dysfunction also comes from core weakness, which most of us have core weakness at some point or another. Like, if you can do a forward plank and a side plank and a back plank, and you can do that all great, you probably have a pretty strong core. You can do a push-up with perfect form, but most of us really don't. So we're pretty much always going to work on just some simple core strengthening exercise. And that can also be as simple as, when you're standing, I want you to think about just tightening the muscles of the core to try to hold yourself a little bit more erect. And think about that when you catch yourself in a slump. Just try to pick that up. Can you all hear me? Am I on this? Okay. Is that better? Okay, sorry. All right. And then gait. We always, of course, are going to look at gait. My evaluation starts the second I see them stand up out of the chair in the waiting room. Hello, Mrs. So-and-so, if you're ready to come back now. And I can tell quite a bit just from watching them get out of that chair and walk and turn the corner to come into my room. And sometimes I'll even say, let's just go ahead and walk down, around the room one time together while I'm saying hello. And that I've gathered a lot of information just from that one simple task. We actually use a lot of different outcome tools. If you're in therapy or nursing, you probably are very well versed in outcome tools. You want to see if you can measure as objectively as you can, if someone is actually getting better. With people who have dizziness or vestibular issues, I will have them do the Dizziness Handicap inventory. Are you all familiar with that? Anybody use it? No. Okay. It's a 25 item. Well, I'll talk about. Let me show you this whole list, and then I'll talk about them a little bit more. Berg is a balance test, dynamic gait index, activity-specific confidence, and then we have a computer that's a little bit more of a sophisticated measure of how bad is the balance and how do you stack up normatively against your peers of your same age. Simple things, and some of these norms, you'll see it a little different from one research article to the next. You might see a little bit of variation in this, but this is in the ballpark. The timed up and go test, it's essentially you're getting out of a chair, walking 10 feet, coming back and sitting down, and you see how long that takes. And you do 3 trials and average the 3 trials, but that should not take more than 12 seconds. And if it is, then it's indicating that that person has an altered gait speed, which is also a very high risk factor. The folks who are walking slowly are at a higher risk. You see that. You can just see people in the community that are just getting along real slow. They're high fall risk. You can see that just from looking at gait speed, but this puts a little bit of a measure on it. 5 times sit to stand. Can a person, without using their arms, stand, sit, stand, sit, stand, sit 5 times in less than 15 seconds? And lots of older people can't. You can check yourself at some point and see if you can, but that's an indicator of muscle weakness in the lower body, the core. And then, of course, the one-leg balance. If you can't maintain that for even 5 seconds, then that's another indicator. The Dizziness Handicap Inventory is like a really easy tool to use to see how it's the person's self-assessment of their dizziness. How bad is this to me? And it's broken down into 3 categories, some of which are physical, emotional, or functional categories. Things like, are you embarrassed because of the way you walk? Are you afraid somebody will think that you're drunk because you're weaving? All kinds of, can you get a shoe from in front of the, I don't know, there's just a whole bunch of different questions that they answer. And they tell you with each item what their confidence is, 0 to 100%. I can do that 100%. I'm not afraid at all. I know I can do that. To know, I wouldn't even try that. And so 100%, is good. So the lower the score on that, they're really afraid. And that fear of falling is a huge risk factor as well. Once you have an incident or you become fearful, you tend to do less and less. Your activity goes down farther and farther. You get weaker and sicker. And the fear can just put you in your chair and gets these people started on a downward spiral. So when people are afraid, you need to be finding the help for them so that they can find out, is this something that I can improve? Is this something I can do something about? Is there anybody that can help this? The Berg I use a lot. It's a balance assessment test, and it's actually better at predicting people who are falling frequently versus trying to predict, I think you're going to fall in the next 6 months. It's going to predict more the people that are having these frequent falls. But the scale is 0 to 56, and anything less than a 49 is considered a fall risk. The lower the score, the greater the risk. We had a lady that she just graduated from therapy last week, and she started with a score of 21 and stumbled into the clinic, grasping at things, literally. And we actually kept her in therapy, rightly so, for like 3 months, which is kind of unusual. But her scores kept getting better and better, and she graduated with a score of 41. But here's what was on her side. She had like everything wrong. She could hardly see. She had poor sensation, and she had a lot of musculoskeletal weakness. She had just so much going on. But here's what she had going for her. She had very good judgment, and she knew what her limits were, and she was very careful, and had somehow managed to not hurt herself. But she at discharge is actually walking with much improved confidence, not perfect, but made just a tremendous amount of gains because she was trained how to compensate for her losses, how to use assistive devices properly, and how to continue to respect the reality of her fall risk. The Berg is really good because I can tell people, I can show it to them and say, you scored a 39 out of 56 points. And I know you don't want to use a walker right now, but let's just try to do that right now. That's the recommendation because you're at such a high fall risk. And then let's work in therapy and see if we can change that score. Let's see if we can get you up above that 49 and improve your true safety and confidence. Because, and you know, I say I don't mean to try to frighten people. I really don't. But, you know, I do tell them the statistics about how often people over the age of 65, how often they fall, and the mortality risk associated with that is just, it's just not a gamble that you want to take. And that is the approach I tell people. It is a gamble. I mean, of course you have the will to say you're not going to do it or you don't want to, and that is your right and your choice, but I would recommend you do this because it's just like gambling. I really am afraid you're going to be somebody that falls and really gets hurt. And I think they've never had anybody really, at that point, I've had several that, you know, they've just never really had it put to them like that. And sometimes you just have to be kind of honest with people about their risk, and then they make their choices around what they're willing to do. So the Berg is a good one. There's also a dynamic gait index, and it's more directed at people who can kind of move around a little bit better. It's like an observation of gait. It's like change of gait speed. Can they walk slow and then fast and then slow and then fast? And can they walk and turn their head and keep walking a straight line while their head is turning? Or can they walk and look up and down while they're walking and keep a straight line? And when you see people that are veering left and right, that kind of guides your treatment choices about what you're going to do to try to improve on that. We also use the ABC scale, which is activity-specific balance confidence scale. It is, again, a patient's self-report of their confidence level. And then the Balance Master, which probably not explain too much, but in essence, it's a computerized system that you stand on a force plate and a computer, and it measures your postural sway. So if I'm standing, first condition, eyes open, firm surface, and I can stay stable in that environment, that's the first condition. All systems are on, they're doing pretty good. Second condition, eyes closed, and if you see an abnormal amount of sway, which is age norm sway, then that gives you some information. I've taken their vision away. They're left with musculoskeletal and vestibular. Took the vision away. So third condition, you're on a piece of foam. So I've made the surface compliant. It's, you know, they don't have that stability under their feet. So I've taken away something from the musculoskeletal element. Eyes are open, but they're having to use eyes and inner ear more heavily. So that'll tell me if the musculoskeletal system might be mostly to blame if they fail on that condition. And then the last one that I generally do in a quick assessment is eyes closed on foam. And the vestibular people who have vestibular loss, think about that for a minute. I've messed up their musculoskeletal system by putting them on foam. I've taken away their vision, and what they're left with is inner ear. And so those folks, as soon as they close those eyes, they go. And so then that you have a clue that they're not able to use that system very effectively. So Dr. Canlis likes to see those numbers, and it'll show, you know, which condition they failed on. And then I try to write a note about what does that mean to me, and, you know, what kind of therapy am I going to do because of that. I think Dr. Canlis pretty much covered all these things. One of the things that it's difficult for physical therapists is when folks have really a cognitive deficit where they're not able to retain the information or they're not able to remember to use their walker. And she can use, Dr. Canlis will refer for cognitive evaluation to see really, what is the status of that. But a lot of times these are folks that just need some degree of supervision. They probably are at that point where they're just needing to be looked after. And family education is a big thing at that point. The prescription medicines, the medication review that Dr. Canlis talked about is really important. When you see people that have a list of medicine like this long, right? How can you really not be dizzy? Probably. There's probably dizziness in there somewhere. So it's just the more medicines that are tacked on, it's sometimes just a necessary evil. They need it to live, and so you can't always just not have medicine. I'll run through this real quick. I see patients who have positional vertigo. What happens with this is, I'll give you a brief explanation. The inner ear, you have crystals, like calcium carbonate crystals that sit in a certain part of the inner ear called the utricle, and they're your gravity sensors. And as we age, those particles can become a little less well-deformed, just like any other degenerative process. They just aren't as attached in there as tightly as when you're younger, and it's common over the age of 60 for this to happen. What happens is you make a turn, you roll in bed, you tip your head back to wash your hair, and one of those little pieces of stone goes roaming out into a semicircular canal where it doesn't belong. And so it's stimulating all those little hair cells and all the neurological loop that tells you you're spinning and you're falling, and it's that you literally don't know where you are. You literally are just like you're free falling and you don't know what you're going to do. It's very frightening. Good news is there is something that you can do about it. This case, a 60-year-old female, in the past week, she'd had 3 episodes. Every time she'd roll out of bed, she'd always get out to her right. She would have this brief period of hard spinning sensation, and it happened once in the shower. A hallmark, kind of a classic hallmark of the most common form of positional vertigo is short duration. So you move, there's like this brief little few seconds where nothing happens, and then bam, it hits you like a ton of bricks. But it will be short-lived, and it will last for generally less than a minute, and then it's like, whew, I don't know what that was. But it makes you feel very disconcerted and very, very afraid of this happening again. So if you don't get treatment for this and it keeps happening, before you know it, you're self-limiting your activity, which again, is what we've all talked about so much, is not losing our activity level because it's such a downward spiral. So our objective observation with this patient, I want to make sure that, I get patients after they've already been cleared by a doctor, but I'm always going to check for things too, like is their strength symmetrical, have they had a fall and had a trauma to the neck that hasn't been evaluated, have you all of a sudden lost your hearing, has something changed with your vision. You want to definitely make sure the cervical spine is okay, that you're not suspicious that something has gone on with that. You want to always check blood pressure, because I have had patients that come in supposedly with BPPV when really it ends up that they have orthostatic hypotension, so they're just dropping out when they get up too fast, which is really a different thing, although patients might kind of describe it the same way, really. But these folks will be pretty normal when they're just sitting and I'm evaluating them. They're pretty normal until I lay them back into the provocative position called a Hall-Pike-Dix test, where it's a quick, you're sitting, and I keep everything supported, and then it's a quick lay down with head tilted back in one way or the other. And you tip them to the left and nothing happens. Okay, nothing, no, didn't happen. Sit up, tip them to the right, and the room spins. And I've literally had people like grabbing me, you know, and hanging on to the furniture and screaming. You may have heard that at some point. Tim comes and helps me. I usually have somebody stand by just in case because it's so frightening for people. But the treatment for it, you may have heard the Epley maneuver. That's a pretty common term. It's really kind of an old term, and now we call it canalith repositioning treatment, but it's just a series of movements that literally, like, if you had a box that had the little, you've seen the games with the little metal BB, and you try to dump that somewhere, that's basically what you're trying to do here. You're trying to get that particle that's out where it doesn't belong to literally systematically dump back out of the offending canal. And if you truly have a positional vertigo, it's like 85% effective. And so then people are amazed because we go through the treatment cycle, which is really nothing, it's pretty easy. And then we let them sit for a while, and then they lay back again. And it's like, you know, it didn't happen. You know, it's like, wow, where did it go? And so it can be as easy as that. It's not always as easy as that. Sometimes the treatment has to be repeated. Sometimes there's more than one canal involved. Sometimes people need follow-up vestibular rehab if they've had it for very long and they have ignored treatment for a while. And the system is just, from that lack of head and neck movement, the system is just kind of shut down. And so we need stimulation to get that going again. That's where the vestibular rehab comes from afterwards. So this lady, her findings were consistent. The posterior canal is the most commonly affected. I have actually the Frenzel lenses in the clinic that's hooked up to a computer so I can see the nystagmus if it happens. It occludes their vision so they can't fixate and stifle that nystagmus. Nystagmus is like that quick eye, crazy eye movement, if you've ever seen it. It can be torsional, like a rotational torsional. It can be horizontal or vertical, and different directions mean different things. But with a posterior canal, you'll typically have a torsional upbeating pattern, and that's the most common. And the treatment is a series of movements that are done to try to move the offending particle. And then we follow up with what's called habituation exercises, where you're actually going to move that person through some, the Brandt Daroff is actually you're sitting on a couch or the side of your bed, and you turn your head one way, lay down quickly. If you have a symptom, you hang out there until it slows down and stops, and then you're up quickly. So you're trying actually to stimulate that vestibular system to acclimate to normal again. The Brandt Daroff is actually like a secondary treatment for the canalith repositioning treatment too, because it actually can inadvertently move that particle. So sometimes that's done. A big point to be aware of with anytime you're looking for BPV, you want to make sure you're not occluding the vertebral arteries. You know, if I ever had someone that was like, "Ooh, I'm getting lightheaded," or things are going dark, I'm out of there. We're up and we're going back to the doctor. But generally, if it is truly just this, they are pretty freaked out by it, but they're with me. They're telling me what's going on. They're not, feeling numb in their body or anything weird like that. It's just this spinning, weird, horrible sensation. I'm going to skip this one because I think you guys are probably wanting to go eat some lunch or whatever. But there's a lot to talk about with fall risk, and what we've spoke of today are probably just the tip of the iceberg. But I guess my last word would be just if you find people that you know in your heart they're at risk, they're not doing well, encourage them to seek out the proper avenues of assistance with, make a doctor's visit with fall risk as your primary. You want to talk about that. What can I do about it? Who can I see for this? Is there someone that can help me with my dizziness? Is there someone that can help me with my falling? because there's lots of therapists that are able to help on the end that I work in, and then if you can find a physiatrist that specializes in the kind of the whole picture, holistic look at a person, then that is a very good place to go to. So, any questions? Sorry, it's like already 11:30. Yes, ma'am? Okay. Both ears? Okay. Once you have, my understanding is once you have bilateral complete true loss, that does not come back. But what the treatment is to learn how to compensate for it. So you compensate for it. You learn how to use your other systems better, and you use assistive devices if you need to. So you substitute with walkers or a cane or lights being on, you learn to substitute, and then you learn to compensate. And that is still an appropriate person for vestibular rehab, although we're not going to be able to rehabilitate that system. Yeah, and it's compensation. It's how do you teach your brain to overcome that loss. Yes. Honestly, we do that in our clinic all the time. I'm sure lots of physical therapists would understand that scenario and know what to do. But come see me if you want to cross the bridge.
Do we have any other questions?
Thank you.
Thank you, and thank you very much.